Prognosis of MS, extremely variable. So we now can diagnose really early. So we can see people on their first attack, what's called the clinically isolated syndrome, which actually is the fourth subtype now. So it's their first attack of inflammatory demyelination of what's going to be MS. And sometimes we can't diagnose it after that first attack. Usually we can't unless there's changes on the MRI. But we have a pretty good idea of what happens to those individuals after that first attack if they've got certain changes on the MRI. And we consider that the start of MS because that's the clinical start. We can go back even further and just look at people who have had MRI changes, nothing clinical. They have an MRI scan because they had a bump on the head or a bad headache, and the MRI looks like MS. And we call that radiologic isolated syndrome because it looks like MS, but because they've never had a clinical event, we're not prepared to diagnose them. But we have studies that show that if the MRI is characteristic of MS, then there's a pretty good chance over the next 3 to 5 years they're going to have another attack or develop these signs or symptoms of multiple sclerosis. So because we're seeing people very early, we're seeing a very broad prognostic range. So we knew from autopsy studies in the past that there's some individuals that go their whole lives with MS and never know they have it. Now with MRI scans and this radiologic isolated group, we're picking up some of those people. Now some of them will go on to develop MS, some won't. So that's the far left, the best side of the prognosis. Relapsing remitting can produce mild or severe disease, but the most severe disease we see is usually when people transition into the progressive phase, either secondary progressive MS or primary progressive MS, and there you'll see difficulties with ambulation and bladder and eventually upper extremity and swallow. But our ability to predict early on is very poor. And we like to think that we can give people an idea of what's going to happen, but we're really not very good at it. This has a practical implication because with a range of therapies from pretty benign to very aggressive with potential safety issues, it would be nice if we were able to prognosticate really early on who was going to do badly because you would put them at more risk with a more aggressive therapy. And we're just not at that stage yet.